it's always good to hear from someone from a different background. Indonesia is one of Asian countries, so we have more knowledge about Indonesian kesehatan, BPJ's kesehatan, national health insurance scheme, but we are not really familiar with the African healthcare system, what's going on over there. So it was really nice for us to have a better understanding of Rwanda and also other African countries' healthcare systems. It seems like we have some common challenges as well as some differences in terms of we are dealing with, in terms of things we are like dealing with at this moment. So I'd like to toss my microphone to Ms. Nalali for to conduct this discussion session. Thank you.
Thank you very much, Mr. Cho. Thank you, Regis. Thank you so much for your very insightful expertise shared with us today. And it's impressive to see how it all evolved and how your scheme is Africa's most successful. So congratulations. Of course, it's work in progress, but it's very impressive to listen to you. I think today we are in a group where we also have maybe expertise from the group that people don't have yet had the opportunity to share. So this session is of course a Q&A, but please feel free to stand up, to present yourself, and to react to the presentation with a view from your institution. So if you feel easy sharing, standing up and sharing how it's going in your country, or what this appeals to you, feel free. This is your moment. We have half an hour discussion, but it can be also a short presentation from your end, so feel free. To start with, Professor Mukti, do you have any reaction to Regis' presentation or any question to him?
Yeah, I think that's very good, but the problem is a little bit on the fee-for-service, because fee-for-service payment is always not quite efficient. This happened in Indonesia a long time ago, and then we have to pay a lot to the healthcare providers. But now, because we are big, so we can dictate the specialists, the hospitals, how much we have to pay. But of course, like in Korea, we have to negotiate. It is very not easy to negotiate with Association of Healthcare. So I think the only thing, that one, and the other one, for our colleague from Rwanda, there are many, at least 3 types of schemes. So if you gradually then merge, like in Korea or maybe like Indonesia, will much stronger. At least you are like that. But I think I would like to ask my colleague from Iran. Yeah? He has very, a lot of experience and things like that. So we hope. But I know that you are the health economic, what you call it, professor or lecturers. But now he is working in the social health insurance. So.
Okay, thank you.
Thank you very much. Thank you for your nice presentation from Rwanda. I actually enjoyed that. But my name is Shahram Ghaffari. I'm from Iran. I am a physician actually, but I studied health economics. So I am a little bit familiar with the concept of economics and health economy. What I'm asking actually from the Rwanda is whether they have the service benefit package. Is the just one service benefit package or 2 service benefit package, which is one is national one, mostly is a big one, or the comprehensive one, and this, the insurance service benefit package, which usually do not cover all things in the country. The question that I am asking is that, but I would like to know how the other country actually deal with such a problem, because this is the problem we are facing in Iran. We have 2 service benefit package, which is national one, and the second one, the service benefit packages specific for the insurance company. So the problem arises from that when the services provided by the physician, which is not covered by the insurance company, raises many problems in the health context and actually affect accessibility, affordability, and equity. So I'm interested to know much more about that, and many other things I actually prefer to for tomorrow, because I'm going to present tomorrow in one slide.
So Regis, do you want to react to this question first?
Yes, the benefit package is a national, so there is what used to be there, and there is a last year's reform that you are trying to implement. So how it is now, it's actually we are covering services that are included in what we call service package. So it's the government of Rwanda that decide the service package, and all the insurance have to cover that. But we realized that this is not sustainable, and recently there is because there was no much of how can I say analysis included in the development of service package in terms of cost effectiveness and that dynamic nature that we would like in developing benefit package. So recently there is a new guideline that every insurance will have to develop its own benefit package using HTA as a methodology and factoring in its capabilities of covering services. So before that comes, we were using the service package, and the universal health insurance, because of its underfinancing until at least last year, we were using that with a negative list. So we're saying we are not covering this until we have sufficient resources. So it's from service package, and we were selecting few services at a tertiary level, at higher levels that we can't cover, and we say we cover this when we have resources. But going forward, will be every insurance will have its own benefit package developed using HTA, and we have already started with the analysis of different services that were not yet included in the package, so that starting with cancer, actually, we are soon getting a decision on which cancers that we are covering from December going forward. So that's what I can say.
Okay, just one more. Are the physicians allowed to provide services beyond the national service package, beyond the national insurance service package? If they do so, what's your actually plan to deal with such a problem?
So physicians are allowed to provide, because the service package is only updated every 5 years. So we recognize that there are always new technologies, new ways of doing things. So we always allow medical advisor to approve, to conduct a very quick assessment. Let's say, for example, there is a new technology, minimally invasive surgery, that is doing better than the traditional surgery. So we kept that flexibility of allowing to go beyond the service package when the medical advisor is convinced that this is the right thing to do. Same for medicine. So we use to receive new medicine that are doing there is that always cost and outcome comparison, even if it is not formally done through HTA. So the doctor will try to analyze the difference in cost and the difference in outcomes between the existing technology and the new technology, and take decision accordingly.
So you want to react, Professor Mukti?
Yeah, I think this many countries happen, and very, so our colleague from Iran is the doctor, and I'm also, formerly I'm a doctor, but now no more. So the doctors want to be paid high. Always, if the specialist, they want to be paid very high. And in Indonesia, a long time ago, the hospitals and specialists, they can determine the price, the tariff by themselves. That is in the past, but now BPJS who determine that, and also the Minister of Health determine the tariff. If, for example, that doctor is very famous, and many people want to go to that doctor, so it is allowed. Then mostly are those who are very rich, who come to that doctor. So if they are rich, they have to buy additional health insurance. That is usually profit-oriented health insurance, commercial one. So that people, that person have two type of insurance, public insurance and also the private insurance for the profit. That can cover that. But in basically, actually, all type of medicines, as far as it is medically indicated, and inside the national formulary, where the Minister of Health who set up the formulary, so there is no additional cost as far as the medicine inside the national formulary. So the physicians who are very smart, they have, they cannot remember many names of the medicine, whether inside national formulary or not inside. If not inside the formulary, so the patient have to pay additional. So therefore, the doctors who use the system, they know that this drug is under formulary. But anyhow, we are based on the INA-CPGs, or we call it prospective payment. So if your diagnosis like this, whatever the drug, whatever methodology, new surgery or whatever, you can do it, but the price is like this for this diagnosis. Of course, if there is new medicine, like our colleague from Rwanda, they have to go to the health technology assessment first. If it is cost effective, proven, then it can be included in the national formulary.
Thank you, Professor Mukti. So I open the floor.
Yes, may I? Yes, I like to make a couple of points about his presentation. The National Health Insurance Service or National Health Insurance is supposed to like support the poor, right, from the rich population. So according to his presentation, the rich population pays like $7, and the poorest pays, and the remaining populations pay like $3 per month. That's right. Okay. And it is also cross subsidy. But to share the current experience, the super rich guy, hopefully I wish I could be one of them, but super rich guy in Korea pays $13,000 per month. What about those poor? They pay less than $10 per month. Now we call it a cross subsidy because those rich people, they do not really need services, whereas the poor group of people are like they are more likely to use healthcare services, but yet they are entitled to the same level of benefit. So we call it is a very strong cross subsidy, but we are still working on to make it happen in more effective way. So that's one thing that I like to make point out. And the second thing is that there is a voluntary household contributions. I have some doubt if it's voluntary. I don't think it's going to work really well. That is based on the Korean experience as well. Like back in 1976, for the first time we enacted national health insurance law in 1963. It was a voluntary based. Then you can guess what happened, right? Out of a selection, those who were in need of healthcare services were more likely to join the insurance. But those who are rich and young, and who did not need services as much as those like poor and old, they try to stay away from insurance. So we realized that voluntary-based health insurance would not work. So we revised the act to make mandatory in 1976, and 1 year later, we implemented publicly funded national health insurance because we knew that maintaining a voluntary-based health insurance would cause some adverse selection, and that leads to financial threat. So that was a thing that I wanted to point out about your presentation. So thank you again for your presentation.
I just would like to add a little bit, Joe. I think what Joe said is the also experience of Indonesia. When previously, long time ago, it was, optional. They can, as the member or not as member. What happened? Very few people won. Yeah. So now after the year 2014, it is compulsory. So you have no choice. You have to subscribe and to be the member of BPJS. If not, then something will happen. We connect with the public services. For example, for buy the land, or maybe buy house, or go to the Hajj, or whatever. They have to have, it is compulsory. Then happen. When like Rwanda at the time, then we have 300 local government initiative schemes, 300. Now it's much into one only. Okay, thank you.
Good evening, everyone, and good evening, honorable guests. And my name is ㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡㅡ I'm from the National Social Security Fund of Cambodia. My question is related to the healthcare coverage expanding of my country. Actually, in this year, the government of Cambodia aims to expand healthcare coverage to the dependent by voluntary. But actually, I hear from all of you talks about the voluntary scheme is the hard for the reach out to people to register in the institutions. Because my country is developing country, that's why we first to set up the first state for the
recording in progress.
Expands the social security on healthcare scheme coverage to the dependent by voluntary. My question is, the problem is we cannot, we do not have experience to determine the contribution rate for the voluntary scheme for the dependents. So I would like to know about your country experience and how do you determine the contribution rate for the voluntary scheme on healthcare scheme for the dependents and health. And for the second questions, I would like to understand is what are the challenges and what are the challenges when your country have been implemented voluntary scheme in the country and then change from the voluntary to mandatory scheme, and what are the challenges? Because if we cannot, which means that if we do not determine the contribution rate truly and sustainably, so it will face the challenges in the future. So right now, I would like to know about the experience before from your country. Thank you so much.
Yeah, our colleague from Cambodia. I think to expand to the member of the family is much better. But again, I think for the voluntary basis, yeah, that is not easy. Of course, in my opinion, if possible, should not optional, but if they are not be able to pay, then it is the commitment from the government, whether central or local government have to commit. So they have to pay little bit and maybe can make grades, if they rich, no need, a subsidy, but if they poor. So like in Indonesia at the time, before 2014, there was a book entitled, "The Poor is Forbidden to Fall Sick." But now I said, for the poor is forbidden to pay when they fall sick, because the government is paid as the premium, something like that. But of course, for the roadmap as the gradual, first the voluntary basis, then like in Indonesia for the 1% payment of the salary, they have the right for wife, then the husband or husband and wife, and 3 children. So if they have more than 3, sometimes, then they have to subscribe. They have to, that is optional, but actually compulsory, because everyone have to as the member of the BPJS. Do I answer your question? Yeah. Oh yeah, the challenges, of course, because to make it as compulsory, not all people happy. Yeah, yeah. Because if people to pay, they do not want to pay actually. They want to use without paying. That is what actually they want. But of course, then we use many type of mode and approach. That is our challenges. For example, we work together with the police, national police. If somebody want to process the motor license, they have to be asked by the police whether you are the already member of BPJS or not yet. But then the police, they are not brave enough. So they said, no, not now, maybe in the future, something like this. That is our challenge. Of course, in other type, of the department or of the ministry, there is a challenge. But anyhow, now we still have for the missing the middle around 6%, and mostly informal sector. So informal sector is not easy, because sometimes they got the salary, the money, sometimes not in this day or the following day, something like that. In my opinion, we have to have approach to the government. So as the government, you are responsible to pay that very difficult situation of informal sectors, but sometimes not successful to convince the government. So that is our task, our challenge. Okay.
Yeah, I totally agree with Professor Mukti, and voluntary-based health insurance. I think you need to be very careful, because not everyone would like to join and pay their premium. So it's in our innate that we don't want to spend our money, right? So but even if you go to like compulsory or mandatory, there are 2 types. Like even though sometimes you adopted like a mandatory approach, sometimes if you do not have a reinforcement measure, it works as like voluntary, just as like voluntary. Because if you do not have any reinforcement measure, people, they will, pay. They don't want to pay the premiums. That actually happened to Ghana. Even though they adopted a mandatory approach, mandatory like health insurance-based system, they did not have a reinforcement measure. So it just worked as a voluntary, because there was no measure to force people to pay into the system. So I would suggest that if you are, it's not, well, considering your context, if you think still if you still believe that voluntary-based health insurance could work, please go ahead. But from experiences that happened in Korea and Indonesia and in other countries, they were not proven to be very effective. So that is my one suggestion. And how we did it was that even though it is an insurance-based, health insurance-based system, we could still have some poor group of people covered by the government tax. So we could approach the government for a group of people who live under poverty, who cannot offer to pay into the system. We should define them as beneficiaries of other social insurance or social protection program. That actually happened in Korea too. In 2077, we started a publicly funded national health insurance with 500 employees or more. In the same year, we started to cover the poorest group of people with the government tax. So you can still, even though it's not tax-based, but still insurance-based system, you could still have a defined a group of people who could not pay into the system and go and approach the government for their coverage. Yeah, and also there are so many challenges. I mean, like sometimes you have to persuade them pay into the system, but if they still do not pay, then sometimes you go after their properties and bank accounts, and during the process, there are some conflicts. But again, for you to have a very effective system, you need to have a reinforcement measure, which is based on IC technology and a very efficient system. Otherwise, it will be very, very difficult to cover the entire population. Thank you.
Thank you, Mr. Cho. So we have 5 more minutes, and I think a lot has been shared already, but I wanted to react to what you just shared, Mr. Cho, because we're talking about the missing middle, we're talking about the poorest, but we're also talking about not necessarily don't wanting to pay contributions, but this group, let's say the non-traditional employment structures, often induce income volatility. So people don't necessarily have consistent access to healthcare during periods of fluctuating income. So how can we address this efficiently? I don't know if Régis, you want to react to this, or Professor Mukti, or any other person?
Yes, thank you. The missing middle is a big challenge, and the discussion about having a compulsory scheme and not a compulsory, it's also a big discussion. Recently in 2016, there was a health insurance law that makes it mandatory for everyone to have an insurance. So our universal coverage scheme is not mandatory, but it's mandatory for everyone to have an insurance. So it doesn't prescribe where you should have your insurance, but even foreigners living in Rwanda should have an insurance after 1 month spent in Rwanda. So we use that as a leverage to try to mobilize everyone to show that you need to have an insurance, but there is no punishment to someone who can't, because we understand there are people who sometimes have shocks. They were not identified as poor, but they are unable today, tomorrow they are able, where we see intervention. So it's the way we try to reach universal coverage is a combination of efforts, and it's a shared responsibility between central government and local government. Every district mayor in the local government has health insurance coverage as one of KPI, key indicators. So when they realize that they have a group of households that were not identified as poor, therefore will not be covered by government, but probably have had shocks or are in a certain period, maybe the harvest was not good in that year. So it's a temporary situation. They work with NGOs to identify them and cover for them for that year. Hopefully that they will be covered in the following year. So it's a mixture of multiple stakeholders and multiple approaches to making sure everyone is covered. And it's also that government incentive, because you contribute only $3 per household member. Maybe if I address the dependence part, they have to be all included in the coverage. It's also the government incentives also is showing actually the cost of care is double. But when you pay your half, government will be covering the other half, and you have full access to services. I think that is also an incentive, because when you don't have an insurance and you go to seek care, once you will realize next year I will have to pay my insurance. And the subscription to insurance is always open, so people can join anytime they come, but it is on annual basis. So we close the year in June and we start in July. So even if you realize you need the services today, but the good thing, majority pay in the first 3 months of the year, which helps the scheme also to be sustainable. Thank you.
Thank you, Régis. So I will leave the 3 last minutes to you, Professor Mukti, because we're talking about health for all, but I hear you're coughing, so you really need a coffee. So please, the last question or last remarks are for you.
Yeah, I think this is very important because those who are very poor, of course, at least in my opinion, 3 approaches should be done. First, the government or local government have to responsible. Then if we fail, then in Indonesia, for example, we call it the budget innovative, those who are interested in JKN. So we approach the rich man. For example, there is a rich man in Indonesia, that time he gave around 5 billion rupiah. So we divided by 15,000. So this money is to pay those who are very poor or those who, so the people can determine also who should be paid by using that money. So we are open. So it is like, a virtual account. So the money is not in the BPJS, so they can use it. So very transparent. That is number 2. Number 3, of course, the resource mobilization. For example, like syntax, like, the local government who has the tobacco, they have to pay 37.5% of the tax of the tobacco to pay to the BPJS, something like that, and many things. Thank you.
Thank you very much, Mr. Hitimana from Rwanda. Thank you, Professor Mukti, and I give back the floor to you, Mr. Cho.
So this is a good time. I think you have unfinished comment in the morning, or if you, it doesn't really have to be about this presentation, but if you can bring up any topic or any comment that you would like to share with us, it's a good time because not many people here and you'll have a bunch of time to discuss. Or Natalie, can you
Yes.
jump in and...
Yes, does it work? You hear me? Okay. So I think the presentations this afternoon were very diverse and very complementary. And I thank the honorable speaker from Nepal and from Cambodia. And also, I think we have touched upon many topics. Maybe to come back to the intervention of course, the colleague from Cambodia, which is also a little bit linked to what Mr. Gombert shared in his presentation, because he talked about a form of extending healthcare coverage through what he called aller vers approach, which means going towards people. And this is maybe relating to what you thought about outreach, social media, making sure that people are informed and know about the benefits they're entitled to. So I think this way of moving towards people is always also being, of course, induced maybe more by the COVID-19, and be sure that all people had the necessary care they needed or they were entitled to, and also virtually. It tries to combat the non-take-up of benefits. And I think this is maybe also for the future a very important way to get people to provide, to receive the care that they need at affordable costs, of course. But the first thing is to inform them that they know where to get the care, how they can be entitled to it. And this is maybe one of the major, let's say, hiccups of our systems. What do you think?
Okay, thank you, Madam Natalie. Of course, for our implementation, yes, of our one project or scheme, if we want to rig out our implementation as well as the plan that we need to disseminate yes, to our member, and one more thing, if we need the member to know well about our implementation, and unless we strengthen yes, our destination to our member, especially the benefit that they get from us. Look like example, if we have plans to implement the scheme, to the self-employees. Of course, this implementation is really difficult because why? They can also think, if I register to an ISSA, what kinds of benefit will I get from the ISSA back? So that is why the dissemination strategy is the priority for us to disseminate to our target group. And especially the benefit, how can they get from? What kinds of benefit they receive? And what is the properly way that can make them easy to register? So that's why we also have the innovation in our mobile app that I have already mentioned before. All the information that they register and also they used to register and using service, access service, they also find all those information in application. So this is the key priority that we also mentioned. And beside that, we have to strengthen our dissemination through the social media. As you know, the world right now is also focusing on the social media very much. Then look like, for example, in YouTube or in TikTok, example like that. So this is a very short dissemination, but really meaningful, okay? And we can also get more benefit from this dissemination strategy. Okay, thank you.
Yes, I think it's really important this way to reach the most vulnerable and those who are the most excluded from the healthcare system. So I don't know, Mr. Adhikari, do you want to add anything to the outreach specifically, or any other point that you want to react to from the presentation of Mr. Van Ali? Please feel free to take the floor if you hear as well. So, Mr. Adhikari,
Your voice is not listening clearly.
do you hear us? Is it?
Yeah. Please.
Yes. So I don't know if you would like to react to the presentation of Mr. Van Ali from Cambodia. Is there any additional thoughts that you would like to share with the audience?
Please again. Sorry, your is not clearly about your voice.
I'm sorry. So is there any takeaway from the presentations this afternoon? Is there any major points that you would like to reiterate or just to highlight following this afternoon session? What is for you the most important to take on?
What? About the presentation of Cambodia, you want to ask?
So any specific message for the participants that you would like to highlight? Just one message from your end?
What you want to ask about? Sound is issue, yeah.
So the last word is for Mr. Cho then.
Thank you for. Everyone's talking about universal health coverage, but I believe UHC, well, like according to the presentation, achieving UHC is like a dream, right, for a developing nation. But I would say it's a dream for every country. That includes very wealthy, high-income countries as well, because everyone's talking about universal health coverage, but there's no country in the world that can provide free, quality services without charging, right? So I would say we are just taking one step toward universal health coverage altogether. So that's why French healthcare system fund is also doing their like reforms to make it better. And also Korea, we are taking many reforms at the same time to better provide services for the entire nation. So I would not necessarily, like, if you ask me if is there any country that actually achieved universal health coverage completely, I would say no. We are just we are taking another step towards universal health coverage so that our people can be healthier than now. So so like this wraps up. Okay, all right. So is there anyone from the floor to make a comment? Otherwise, we'll just have a very casual like networking food. It's not a big dinner. So are we okay? Please.
I think it's a lot of food for thought.
Thank you, Joe. I agree with your opinion as well. This is Jivan from Nepal. In Nepal as well, seems that the health condition is gradually growing up positively. While talking about the structural and service mechanism, service administrator aspect of Nepal, Mr. Krishnaji is mentioned the different aspect of the Nepal service provider before his presentation as well. However, he separated his presentations in his organization, that was SSF. However, it was nice presentations as well. While talking about the scheme of Nepal, we have mentions other different scheme which is providing by the government of Nepal, Health Insurance Board, Employees Provident Fund, our organizations as well, and there are so many private insurance company as well. So health assistance program is associated with the totally government of Nepal and it not contributory base, and other institutions, SSF, EPF, HIV, all these organizations is running their schemes on the contributory base. So these are the scheme, and the concept I just mentioned my opinion. The concept was started in Nepal just few years before, even though the community-based health facility in 2003. Even though the government passed the health insurance policy in 2014, everywhere, while we're talking about the challenges, health coverage for all, not only to make this adequate, effective, and sustainable as combined model or package, there are so many issues. I came to know from the Krishna's presentation and other companies and other presentations is that every country have facing the same problem, and more or less the problem is same, and that to make the benefit package sustainable and universalization, they are like raising cost of the health care, changing people expectations, investment in technology, and changing demography. These are the some example obstacle. These are the same around the world we can see. And additionally, countries like Nepal are also facing the more challenges such as coverage, lack of awareness in the medical benefit package. So providing this facility and make schemes sustainable is like a paradox situation. I think providing the facility and making it sustainable is like a paradox situation in every country. So it's my opinion. So hence we can't ignore that every country have their own experience and own stories as well as in this regard. However, this scenario cannot make a prioritize such type of
crucial element or challenge to make the sustainable benefit package. The question is that not for addressing each other, but we should discuss and think that fundamental precaution regarding the sustainable benefit package, the scheme for all means make a universal. How can provide the package of benefit and it make a universal? That is the questions for us, and addressing this type of forum should be discussed in this scenario. It's my complimentary opinion, because we all want to make the big happy family of our members. This type of philosophical aspect, it's my opinion, in this short opinion in this regard. Thank you.
Thank you. Indeed, I agree with your opinion. How can we provide benefits package universally to the people of not only Nepal,